everyone. I am Teacher Jolly. Today, we will learn new things about the other developmental disabilities, such as Down syndrome, Angelman syndrome, Isocentric 15, Fragile X syndrome, Central Auditory Processing Disorder, Expressive Language Disorder, and Landau syndrome. Are you ready? Okay, let's get started. My courtesy to our brilliant and ageless advisor in Foundation in Special Education, Professor Susan Vicente D. Villarente, to my co-presenter, the alluring Ma'am Maria Giselle Suiman, to my active colleagues, ladies and gentlemen, a pleasant day. Today, I'll be discussing the part 1 of the other developmental disabilities. But before we go to the session proper, let us have the objectives. The first objective is to identify the other developmental disabilities. Second, examine the cause, risk, characteristic, and prevalence of the mentioned disabilities. Third, share your experience or ideas on how to deal or handle these types of learners. Let us have a short activity. Can you identify the disability of the images I'll be presenting? Are you ready? Please comment your answer in the comments box if you know. In this image, can you identify her developmental disability? If your answer is Down syndrome, you are correct. Next, can you identify his developmental disability? Did you say Fragile X syndrome? You are right. The last one. Can you identify her developmental disability? I heard you say Angelman Syndrome. You are correct. Thank you for participating.
Down syndrome.
Yes, let us start with Down syndrome. It is a condition in which a person has extra chromosome and has similar facial and physical features. Usually, they have intellectual disability, and it occurs in about 1 in 700 babies. What are the causes and risks of having Down syndrome? The extra chromosome 21 leads to the physical features and developmental challenges that can occur among people with Down syndrome. One factor that increases the risk for having a baby with Down syndrome is the mother's age. How to diagnose? Two basic types of tests available to detect Down syndrome during pregnancy. We have screening tests and the diagnostic tests. There are also three types of Down syndrome, namely trisomy 21, translocation Down syndrome, and mosaic Down syndrome. Now, what are the characteristics of these types of Down syndrome? When we say trisomy 21, with this type of Down syndrome, each cell in the body has three separate copies of chromosome 21 instead of the usual two copies. What about the translocation Down syndrome? This occurs when a whole extra chromosome 21 is present, but it is attached or translocated to a different chromosome rather than being a separate chromosome 21. Mosaic Down syndrome, on the other hand, mosaic means mixture or combination. For children with MSD, some of their cells have three copies of chromosome 21, but other cells have the typical two copies of chromosome 21. Children with MSD may have same features as other children with Down syndrome. How prevalent is this condition? With trisomy 21, it's about 95%. With the translocation Down syndrome, about 3% of the population of that DS. When we say mosaic Down syndrome, it's about 2% of the population of Down syndrome. Now, do you know who is this individual with Down syndrome? A well-known Filipina Down syndrome ambassador.
Is Brianna K. Maximino, Special Olympic Global Ambassador. Angelman Syndrome.
Moving on, we have Angelman Syndrome. It is a rare genetic and neurological disorder characterized by severe developmental delay and learning disabilities. It was first described in medical literature in 1965 by Dr. Harry Angelman, an English physician. Diagnosis. A diagnosis is usually made between 1 and 4 years of age based upon a detailed patient history, a thorough clinical evaluation, and identification of characteristic findings. About 80% of cases can be confirmed through a variety of specialized blood tests, such as DNA methylation. Causes and risks. It is the deletion or deficiency of UB3A gene expression. What are the characteristics of an Angelman individual? There is significant absence or near absence of speech, inability to coordinate voluntarily movements like ataxia, tremulous with jerky movements of arms and legs, and a distinct behavior pattern characterized by a happy disposition and unprovoked episodes of laughter and smiling. They have distinct facial features, including prominent chin, deep-set eyes, an abnormally wide mouth, marcostomia, with a protruding tongue, widely spaced teeth, and abnormally flat back of the head, or brachycephaly. How prevalent is this condition? It affects males and females in equal numbers, and estimated to be approximately 1 in 12,000 to 20,000 people in general population. However, many cases may go undiagnosed, making it difficult to determine the disorder's prevalence.
Isocentric 15.
Moving on, we have Isocentric 15. It is a chromosome abnormality in which a child is born with extra genetic material from chromosome 15. Diagnosis. It can be diagnosed by karyotyping or chromosome analysis is used for testing. And we have FISH or fluorescence in situ hybridization. It is used for the confirmation of the diagnosis for this chromosomal abnormality. The cause and the risk. Individuals with isocentric 15 have 47 chromosomes instead of 46 chromosomes. When the genetic or the extra genetic material comes from the paternal chromosome, a child may have a normal development. However, when the duplicated material comes from the mother or maternal chromosome, developmental problems are often the result. And what are the characteristics of this condition? Isocentric 15 affects the physical and mental development, although the severity of the condition and the associated features vary from person to person. Common signs and symptoms include poor muscle tone in newborns, developmental delay, mild to severe intellectual disability, delayed or absence of speech, behavioral abnormalities, and seizure. They may share similar facial characteristics, including a flat nasal bridge, inner epicentral fold, deep-set eyes, low-set ears, and down-slanting palpebrae. How prevalent is this condition? This syndrome occurs in about 1 in 30,000 newborns. It is not inherited usually and occurs as a random event in the production of reproduction of cells of one of the parents of the infected individual.
Fragile X Syndrome.
It is a genetic disorder because of changes in their genetic material, the FMR1 gene. People who have Fragile X syndrome do not make protein called FMRP, which is needed for normal brain development. People who have other Fragile X syndrome associated disorder are also have changes in the FMR1 gene, but usually make some of the FMRP protein. Diagnosis. The only way to diagnose Fragile X syndrome is with a special blood test called The FMR1 DNA test for Fragile X. The cause and the risk of Fragile X syndrome. Fragile X syndrome is caused by change to a gene on the X chromosome called FMR1 gene. If this gene is changed or altered in any way, it cannot produce its normal protein. Having Fragile X syndrome is associated with an increased chance of intellectual disability and autism spectrum disorder, particularly in males. Characteristics. They manifest developmental delays, not sitting, walking, or talking at the same time as other children of the same age, learning disabilities, trouble learning new skills, and social and behavioral problems, such as not making eye contact, anxiety, fear, worry, trouble paying attention, hand flopping, acting, and speaking without thinking, and being very active. How prevalent this condition? Fragile X syndrome is more common in boys, and the symptoms are usually more severe in boys than girls. Fewer than 200,000 newly identified cases per year in the United States.
Central auditory processing disorder.
It is a condition in which ears and the brain do not work well together. Diagnosis. An audiologist is a healthcare provider or professional who measures hearing loss. He or she will test for any actual loss of hearing, test your child to see how well he or she can tell sounds apart, ask you and your child teacher about your child's listening behavior. What causes and the risks of this condition? Nobody knows exactly what causes central auditory processing disorder. Some children who have autism spectrum disorder and attention deficit hyperactivity disorder also have CAPD, but ASD and ADHD do not cause it. Parents and teachers often first notice the symptoms of CAPD in school, having trouble understanding, discussion in a noisy classroom, struggling with spelling and reading aloud. Characteristics of this condition. People with CAPD can hear, but the brain has trouble processing the sounds. Often, they ask their parents and teachers to repeat what they've said. They have difficulty to difference among similar sounds in words, making sense of what is said to them, blocking out background noise, and knowing where a sound is coming from. With regards on the prevalence of this condition, in the United States, it is estimated of 5% of the school-age children population or 2.5 million children have CAPD. The true prevalence of this condition may be greater due to undiagnosed or misdiagnosed cases.
Expressive language disorder.
It is a difficulty conveying or expressing information in speech, writing, sign language, or gestures. Diagnosis. If your child is having difficulties with speaking or using language to express themselves, it is too important to have their language skills assessed by a speech pathologist, sometimes referred to as speech therapist. Have their hearing tested by an audiologist. The cause and the risk. For many children, the cause of expressive language disorder is not known. This disorder is associated with known developmental difficulties or impairments, for example, Down syndrome, autism, or hearing loss. Many children with expressive language disorder will have an accompanying receptive language disorder. ELD can be developmental impairment from birth or acquired impairment occurs after a period of normal development. Characteristics. Children have expressive language disorder have difficulties combining words to form accurate phrases and sentences.
Sarah Scott.
That's right. What happened after the stroke with your speech?
Well, I can't hold in the heart. close up. So
You had an operation
yeah, it's
in your
that.
heart.
It's that.
So you've got a device in your heart that closed up the hole,
It,
went in from your groin.
yeah.
And how prevalent this condition in the US estimated to be between 3 to 5% of specific language impairment in kindergarten.
Landau syndrome.
Finally, we have the Landau-Kleffner syndrome. It is a rare neurological syndrome characterized by the sudden or gradual development of aphasia, the inability to understand or express language, and recurrent seizures or epilepsy. Children with Landau-Kleffner syndrome typically develop normally until signs and symptoms begin to develop between 2 and 8 years old. Diagnosis: LKS is diagnosed when a doctor sees clinical features that are consistent with the syndrome, such as a loss of speech and an electroencephalogram or EEG that shows specific kinds of seizure activity. Genetic testing can be used to confirm if, if there is a mutation in GRIN2A, but this testing is not done routinely. Cause and risk: LKS is thought to be caused by mutations or changes in the GRIN2A gene. This gene provides instruction to the body to make a protein that sends signals to the nerve cells or neurons in the brain. This syndrome is also characterized by an abnormal EEG, especially during sleep. About 70% of children with LKS have seizures. Characteristics: some children with LKS may develop behavioral problems, including ADHD, temper outbursts, impulsibility, and/or withdrawn behaviors, may also have intellectual disability. As researchers continue to learn more about LKS, it seems that there may be a wider variety of signs and symptoms associated with this syndrome than originally thought. There may be variability of symptoms associated with LKS even within the same family. Now, how about the prevalence of this condition? When a person with LKS has children, each child has 50% 1 in 2 chance to inherit the same gene that causes the syndrome. The prevalence of LKS under medical care is roughly 1 in 302 or 147 to 407 or 420 children aged 5 to 19. Males are more affected by LKS than females.
Interventions.
You have learned already the other developmental disabilities, and now what are the treatment or educational therapeutic interventions? Early intervention, transition, and other educational programs in inclusive education are important to ensure that children and individuals with these developmental disorders reach their full potentials. These school-based and home-based and other significant services include assessment, testing from the prescribed healthcare professionals or service providers, speech, occupational, and therapy, and physical therapy, special social support and other medical, social, and/or vocational services, use of special communication devices such as computer picture-based system, voice-emitting devices, assistive devices, and other modern uses of technology to improve the learning and social communication. Families must have genetic or psychological counseling if needed and available. Provide opportunities in inclusive setting. Develop strong support among parents, SPED, and receiving teachers, peers, significant others, as well as in the community. for children who have seizures may be prescribed with medicine, anticonvulsant medications, and other drugs. And immunotherapy may improve speech and seizures. Surgery when advised by the medical professionals. Thank you so much for sharing your time with me. And if you have questions, queries, and if you like to share your experiences when you came across or you are dealing with these types of learners, please do put it in the comments section. We love to hear it and I love to hear it. I would like you to leave this message from Johann Wolfgang von Goethe. Knowing is not enough, we must apply. Willing is not enough, we must do. I hope this message touched you as a SPED advocate of our learners with special educational needs.
These are my references. Thank you so much for joining me in my session. I hope you learned something. And please stay tuned for the next presenter, the second part of the other developmental disabilities with Ma'am Maria Giselle Suman. That concludes my session. Once again, I am Jolly May M. Pungabong. Thank you, to God be the glory, and have a great day.